Iris claw refractive lenses are currently a safe, efficient, and reproducible way to correct myopia and hyperopia. They can also be used to correct aphakia and are easily combined to perforating keratoplasties instead of cumbersome scleral fixation procedures. A satisfactory anatomical and refractive result relies on the precise surgical technique, depending on various indications. A superiorly pre-placed incision 6.2 millimeters long for implants between -15 and +5, and more for hyperopic correction. 2 secondary incisions at 1 and 11 o'clock are directed to the iris fixation zone, according to the projected image of the lens on the pupil. Miotic and highly viscoelastic substance are routinely injected. Superior incision is tunnelized with a 3.2 millimeter knife. Specially designed forceps hold the lens from the blister and the posterior concavity is checked. Intraocular placement over the pupil is critical. When removing the forceps out of the eye, any contact of the distal haptic might be transmitted to the anterior capsule by the distal haptic. The profile view illustrates these careful movements. In case of superior incision, the lens can be rotated to the 3-9 o'clock position. Accessibility of the secondary incisions is checked with the iris hook. Limited viscous injection under the superior edge of the optic will push back the iris and facilitate lens prehension. Iris insertion is the major movement. The hook will seize the iris fold to be inserted, while the posterior movement of the optic directs the haptic toward the iris. Enough tissue must be captured for safe, long-term fixation. For the second haptic insertion, the optic must be kept centered on the pupil. The downward movement of the optic is critical, and the iris must be pulled anteriorly. A limited pupil dilation demonstrates this. Ten-0 nylon sutures are placed under the macular cover to obviate useless illumination. En-bloc washout of the cohesive viscoelastic is achieved by injecting BSS under pressure in the anterior chamber. For my optic technique, the superficial corneal flap is cut, but not lifted. Implantation technique is unchanged. In the absence of capsular support, insertion hooks may be difficult to use. The iris is grasped by microsurgical forceps through direct corneal incisions in front of the fixation area. On a vitrectomized eye, the viscoelastic material may be aspirated. 10-0-9-line sutures are routine. In case of a large iridectomy, a safety suture will avoid any implant luxation before the iris fixation. This patient suffers from a luxated anterior chamber lens with ciliary contact. CME resistant to treatment has been present for 2 years. Explantation, anterior vitrectomy, and iris fixation lens will stabilize the eye. After 1 year, CME has disappeared and vision has improved. This technique replaces the cumbersome scleral fixation of lenses in eyes without capsular support. Midterm corneal tolerance is satisfactory. Any anterior synechia must be freed to avoid a secondary implant tilt that could endanger the corneal endothelium. Anterior vitrectomy is carried out with separated infusion to avoid more vitreous prolapse. Iris fixation is done through the open cornea. The haptic is kept close to the iris. The iris is seized with microforceps, and the forceps themselves open the claw without damaging the tissues. Conventional graft suturing associates direct and continuous sutures. Precise and adapted techniques extend the indications and safety of the iris fixation lens. They will prevent complications and lead to excellent anatomical and functional results.